Hello, I'm Tony Goldstone. I'm a Professor of Hematology in University College London. I'm an acute leukemia doctor. I was asked to sum up and discuss the perspectives and future directions for the treatment of adult ALL. I was the principal investigator on the largest prospective randomized trial so far, the MRC UKALL XII ECOG 2993 study, and I think that's the reason they asked me to do this. We have learned a lot about the treatment of adult ALL within the last 8 to 10 years. Our results are much behind those of the paediatricians in their disorder, and for a long time we didn't understand why that was. It appears to be due to the nature of the disease. I put this quote on this slide because it was not understood why this happened, and it was even discussed by an eminent hematologist that maybe the paediatricians were looking after their patients better. That was how little we understood 8 to 10 years ago. We've learned two things from the paediatricians. The first thing is the issue of the Paediatric Regimen. What's in a name? What is a paediatric regimen and how does it differ from an adult regimen? It is a high intensity, low delay regimen. It focuses on non-myelosuppressive drugs. It uses Asparaginase intensively, which was not done hitherto in adult patients. Uses a lot of steroids, and there's little or no use for transplant. As these patients did well, the protocols were translated into the adult, but sometimes with some difficulties because they produced some complications. The steroids produced infection. The Asparaginase produced problems with sepsis and abnormal liver function tests, and the anthracycline often caused problems with the heart and myelosuppression. So it wasn't that simple. As we've come forward to the future with adult ALL, we have to clarify how the adult versus pediatric regime is resolved. We think we can translate such regimens up to the age of about 25 or 30, and then we have to become less intensive. We need to work out how all the other drugs are given better. We need perhaps to use less pegylated asparaginase in the adult. And we think that every patient with B-cell disease does need to have rituximab incorporated into the chemotherapy or something else. And in that way, we have considerably improved the output of the adult patients. In the patients with the Philadelphia chromosome, we have been able to use BCR-ABL inhibitors, first generation imatinib, and we're at the present time attempting to resolve which is the best of the TKI inhibitors that one can use. And we're still discussing in the Philadelphia positive patients whether they will come to need a transplant or not need a transplant. But it may be that ponatinib with other chemotherapy will make so many patients MRD negative that they don't need a transplant after that. There are a couple of new major breakpoints in the adult disease. The BiTE or bispecific antibody Blinatumomab is clearly now shown to be the best way forward for a patient in relapse. Many of these patients can still be cured, which was not possible hitherto, either by transplantation or by converting them to MRD negativity so that some of them may yet not need a transplant even though they have relapsed once. This drug is so promising in the relapsed patient that one of the main things for the future is whereabouts more up front in the regimen for the patient that it should be introduced. One of the key issues of adult acute lymphoblastic leukemia is MRD assessment. This is a study from GRAL, the combined French group, which shows how well patients who are MRD negative after induction and consolidation do. The data seems to show that these patients who go MRD negative may not need a transplant and may not benefit from it, but those that have residual disease may certainly need a transplant, and many of them benefit from it. This allows us to go closer to the exclusion of transplants in some patients who are going to do well anyway, and makes it possible or indeed likely that all the other prognostic factors of the disease are overruled once the patient becomes MRD negative. The second great growth point for adult ALL is the use of CAR T cells. This seems again a highly successful technology in the advanced and relapsed patients, but at the present time is extremely complex. One of the key issues will be how to introduce this to a much wider patient population in a much more simple way. And many key partnerships between academics and industrial partners are looking at just that, to see if these highly complex and highly expensive procedures can be truncated to something much more simple, still achieving the effects of the CAR T cells. So, why do the adults do worse? Although the paediatric regimens are important to introduce, at least in part, into the treatment, it's really the disease itself which is a different disease from that in the adults. The protocol obsession about paediatric protocols has deflected from the biological variants, and the real place of this paediatric protocol needs to be determined. MRD negativity is going to be the key issue. The achievement of that leads towards cure and may mean that many patients will not require a transplant. The reduced intensity transplant appears to be of value in these patients, particularly in those more elderly, where the outlook from conventional chemotherapy is extremely poor. If MRD negativity is very important, then it's quite possible now that we can go back and look to the much more simple transplant procedure, the autograft. Probably the autograft failed over the last 25 years in many patients because we attempted to autograft them with significant residual disease, i.e. they were MRD positive. And finally, Blinatumomab, a very promising bispecific antibody, is going to be key to the central treatment of this disease for years to come, and the key issue will be whereabouts in the treatment it is used. Thank you very much.